Welcome to On Call With. During this health and wellness focused production, Fairfield Medical Center is bringing the doctor to you. Each episode, healthcare professionals from every specialty will sit down to discuss medical advancements and share professional insight on tips, treatments, and screenings to help keep you feeling your best.
Well, I'm Dr. Galbraith. I'm a cardiothoracic surgeon here at Fairfield Medical Center, and I'm very pleased today to be joined by Dr. Yenchar, who is going to walk us through kind of patients that have GERD and what the normal workup is and how it's treated. So with that, welcome Dr. Yenchar.
Thanks for having me.
You want to tell them a little bit about your background?
So I am the medical director of the Heartburn Center, and I have been since about 2016. I'm a general surgeon, and I'm starting my 24th year here at Fairfield Medical Center. I did my residency at Ohio State. And a big part of my practice has been acid reflux, and so that's what we're here for today.
Great. Well, thank you for joining us.
Thank you.
So maybe we'll go ahead and start in about what is GERD, and are there things that predispose different patients or people to GERD to know about?
So GERD, or what a lot of people call is acid reflux or gastroesophageal reflux disease. And it's actually a really, really common condition in the United States. Up to 30 million people have acid reflux symptoms, and a lot of them are self-medicating. It's actually one of the fastest growing diseases worldwide, and it probably has a lot to do with the American diet, or kind of our Western culture and how we eat. So that's really a big risk factor for acid reflux. It also is esophageal cancer is one of the fastest rising cancers, and the main contributor to esophageal cancer is actually acid reflux. And so that's where our Heartburn Center, comes in and helping diagnose and treat this. Some of the risk factors for acid reflux, obesity is certainly one of them, alcohol and tobacco use, certain medications, diet, lifestyle issues, and even medications, and that's the main ones. Hiatal hernias is another issue that we see. Okay.
And so the patient on the outside, you may not notice they look a certain way. They tend to be obese. They tend not to be. It can be anybody.
It can be anybody. Yeah, it really doesn't choose. Okay. Young, old, overweight, underweight. Yeah, it can be anybody.
Great. Well, and what are some of the symptoms that people classically, when they come to you, they talk about having?
The most common symptom that people talk about is heartburn. I mean, it's going to be, and in most people, it's usually after they eat, especially if they overeat. So that tends to be really the first symptom that people see. As the acid reflux gets a little bit more advanced, patients may actually, what we call regurgitate, or bring up acid sometimes into their throat. They get that bitter taste in their mouth, or they can have a sore throat when they wake up. Some people also start to have a little bit of trouble swallowing, just because of the swelling where the inflammation is from the acid reflux. And then patients can also come in with what we call upper respiratory type symptoms, which you wouldn't even think would be related to acid reflux, but things like a chronic cough, especially after they eat, or waking up at night with a cough, or feeling like there's something in their throat all the time, or waking up with a sore throat, or even waking up at night with a cough or choking. So some acid reflux symptoms, you wouldn't even think about, because they don't even involve the stomach or the esophagus.
Interesting. And so some of the atypical symptoms are kind of upper respiratory at times. Are there any other atypical symptoms that people should consider?
Yeah, the other one can be chest pain, which is interesting. There was a study done that showed about 50% of patients who come into the emergency room with chest pain, it's actually acid reflux and not their heart. So, of course, they're going to look at the heart first, because that, can be life-threatening. But that actually can be a presenting symptom, what we call atypical chest pain.
Oh, interesting. So say I'm a person, or I'm a person out in the community, and I'm noticing that I have a few symptoms that I'm kind of concerned about, have questions about. Where would I start in terms of if I came into you, and what would our workup look like? And
So there's a couple different ways to start the process. I mean, we have our heartburn center here at Fairfield Medical Center with our nurse clinician, and she's a great resource just to even start the process. You know, primary care physicians can make referrals directly to a heartburn center physician. When we started the heartburn center, one of our main goals was really to try to diagnose acid reflux early. Because one of the things that we noted is we were detecting more esophageal cancer, but unfortunately it was all later stage. So our goal at the Heartburn Center is to actually get people evaluated before they get abnormal cells or before that risk for esophageal cancer goes up. So our standard workup really consists of 3 main tests. The first is an upper scope, where we put a lighted camera down the throat, and that really lets us see, is there any evidence of damage to the esophagus? Is there any abnormal cells that might increase the risk for esophageal cancer? We look for hiatal hernias, and we're actually looking to see if patients really do have reflux. The second thing that we do is we do acid testing. We've got a little capsule, it's about the size of a vitamin, that we can clip to the inside of the esophagus. And for a 48-hour period, I can tell a patient how many times they reflux, when they reflux, what symptoms go with it, and really get an idea of the pattern of their reflux, maybe some of the causative issues, so we can make some lifestyle changes and things like that. And then the third test we do is called esophageal manometry, and this is really a test that's going to tell us why do they reflux. Most people reflux because of one of 3 reasons, and they may have all 3 of these, but there's a valve at the bottom of the esophagus called the lower esophageal sphincter. And so in reflux patients, either that valve is too weak or it's too short, or the third reason is they develop what's called a hiatal hernia, which moves that valve up into their chest, and if it's up there, even if it's normal, it doesn't work. So our workup is really looking at getting an idea of why the patient refluxes, and then that opens up a bunch of treatment options to figure out how can we better control their symptoms.
Okay. So the first step would probably be just coming in for an appointment and speaking with the nurse navigator, and then eventually talking more. Yeah. Now, if I'm a patient that's been on, say I've been on Protonix or I've been on something in the community, when should I think about starting to be more aggressive? Is it just that I've been on it for 10 years? Is it that if I have breakthrough symptoms, when would I want to be more aggressive?
Yeah, there's a lot of different philosophies on this, and it's really changed over the years just because, you know, a few years ago there were all the concerns about being on proton pump inhibitors long term, and you know, now we found out that probably a lot of that, there's not a lot of scientific evidence to support what was in the media. But one of our beliefs through the Heartburn Center is if somebody has been on an acid blocker for at least a year, they at a minimum should have a baseline upper scope. You know, now it doesn't mean you have to come off your medicine, and staying on the medicine for 5 to 10 years is fine, but you at least need to have a baseline, and we're looking for that what's called Barrett's esophagus, or that precancerous lesion. The other patients we see most often are the patients with the larger hiatal hernias, because their symptoms aren't always just reflux related. They can be shortness of breath or trouble swallowing, you know, those kind of symptoms. But also the bigger the hernia gets, the medicine just doesn't help. Another group that we see are actually people who don't want to be on medication long term. You know, they've been on Prevacid for 5 years. They want to come off it, so we do a little more detailed evaluation to see if maybe there are some other treatment options. And then the main group, of course, is those who have been on acid blockers. It controlled their symptoms for a few years, but now they're starting to get some acid coming up, or they're starting to wake up at night. They're taking, you know, 5-6 Tums a day, and it's just not helping. And so once they start to regurgitate acid, the medicines just aren't going to work. Because I think the important thing to remember is that medication doesn't stop your acid reflux. All it does is decrease how much acid your stomach makes. So you're still refluxing, you just don't feel it as much. But when people start to regurgitate, that's when the medicine's just not going to fix that.
Okay. Interesting. So, and you had mentioned an upper scope. What is that, a detailed procedure? Is it outpatient? What does that entail?
Yeah, it's an outpatient procedure. It's usually done under sedation or can be done under full anesthetic. And it's basically a lighted tube that has a camera on the end. It goes through the throat, allows us to look at the inside of the esophagus, the inside of the stomach, in the first part of the small intestine. Biopsies can be taken from it. The procedure itself takes about 10 to 15 minutes. And you have a little bit of sore throat for 24 hours, but you're back to normal the next day. The upper scope is also, if we're going to do the acid testing with this small capsule, it can be put in at the same time.
Great, great. So say that I go down the road and we find out that I do have acid reflux, and I'm either one of those patients that doesn't want to be on medication forever, or I'm having problems with it. What are the options out there for more aggressive measures?
Yeah, so yeah, if lifestyle modifications aren't working and the medicine's not working, certainly then surgery is usually the next step. And through our heartburn center, we have several different types of procedures. Actually, we have three. We have what's called the Lynx device, which is a band of magnets that we can place around the lower esophagus to stop reflux. We have the standard Nissen operation, which is where we wrap the upper stomach around the lower esophagus to make a new 1-inch valve. And then we also have a modification of that Nissen called a partial or a toupee, and that's where we go 180 degrees. All of those procedures can be combined with a hiatal hernia repair. Because the key with surgery is actually going to fix the reason you reflux. We're going to fix any hiatal hernia that we find, but we're also going to lengthen and strengthen that valve at the lower part of the esophagus to stop the reflux.
Great, good to know. And is there a downside? You know, you had mentioned esophageal cancer as being a concern. If I was to let this go and not get something done, are there other things that I should worry about, or that would be a risk to me as a patient?
Yeah, one of the things that can happen, particularly with people with very severe acid reflux, is they can start to get some pretty significant scarring in their esophagus, what we call a stricture. And that area becomes very narrow, and it can become very difficult to swallow. And there becomes a point when if it gets narrow enough, we're kind of limited in what we can do. So obviously we don't want patients to get to that point. The other thing that we can see is, especially in some of these patients with really large hiatal hernias, and I think in the past people felt that you couldn't fix these hernias, but now with the new technologies we have, new mesh, using the robot, things like that, we can take patients who have 50, 60% of their stomach in their chest and restore everything back to where it needs to be. A pretty rare complication of having a large amount of stomach in your chest is it can actually twist. It's called a volvulus, and that's life-threatening. I mean, people can die from that. So it's one of the things that we really want to identify these patients with the large hiatal hernias and at least give them the option to maybe consider getting that repaired. So that's some of the other issues that can happen when you have either long-term reflux or big hiatal hernias.
Okay. And so when we talk about going down that surgical route that you had mentioned, is it, when you do those three procedures, is that an open surgery? Is that a laparoscopic, robotic? Is there a way to choose that for patients?
Yeah, me personally, I do all of my acid reflux, hiatal hernia surgeries, all robotic now. We have the technology here at Fairfield Medical Center, and it really, in my mind, is the best way to do these procedures. We also do them laparoscopically, which again is a good operation. It's pretty rare nowadays that we do these open, maybe in an emergency setting or in someone who's had to have the surgery done several times. But even in that setting, robotic or laparoscopically is better. I think the reasons are that it just, especially robotic, the visualization is so much clearer and better. The mobility you get with the wrist of the instrument allows us to get in places that we can't really always get to in an open operation or laparoscopically. And it just, patients seem to recover faster, they seem to have less pain, and get back to normal activity sooner.
So generally after a procedure like this, what is the amount of time that maybe I'd spend in the hospital, and then maybe when would the average patient go back to work?
So with the Lynx device, most of those patients go home same day. They do not have to stay in the hospital. Standard hospitalization for either the partial fundoplication or the Nissen fundoplication is typically just overnight. The larger hiatal hernia patients can go home anywhere between 1 and 3 days after surgery. So hospitalization time isn't too long. And most of these patients will go home on some sort of a special diet depending on the procedure. Patients who don't really have much of a hiatal hernia can be back to normal activities, including lifting, in about 2 weeks. Patients with the bigger hernias, it's usually a 6 to 8 week lifting restriction.
Great.
So I have a lot of patients will be back to work, within 10 to 14 days.
All right. So, well, thank you for joining us today. And maybe you can kind of do a finishing touch on how patients would get in touch with you or the Heartburn Center, and go from there.
Okay. So we do have, like I said, the Heartburn Center here at Fairfield Medical Center. Our nurse clinician is Heather Luttrell, and you can arrange for a free consult if you were just, say, interested in learning more about acid reflux and deciding if you wanted to at least have baseline studies or even do the full acid workup. She has all the educational material and can just do a really good evaluation and just help guide patients what the next steps are. If you're someone who's been having your upper scopes all along and you want to learn more directly from the surgeons or members of the Heartburn Center, we do have 8 different physicians in our Heartburn Center, and certainly you can be either self-referred or have your primary care physician or even specialist refer to them to get the process going.
Great. Well, thank you very much for accompanying us, and we will look forward to seeing our audience again on the next show, but we appreciate everybody's viewing.